So I just saw Miss Wells. She's a 28-year-old African-American female who reports a history of asthma since the age of 2.5 and presents in the clinic today with complaints of shortness of breath and wheezing following what she referred to as a near asthma attack occurring 2 days ago. However, reports breathing is currently normal. She states that she was at her cousin's house 2 days ago where she was exposed to cats, which she knows is a trigger of her asthma. And at that time reports that the exposure induced an episode of wheezing with what she rates as a 6 out of 10 and an episode of shortness of breath with what she rates as an 8 out of 10 severity. She states this episode lasted approximately 5 minutes. At which time she used her albuterol inhaler, which she states decreased her symptoms but did not completely make them go away. She reports that since that episode, she's been experiencing shortness of breath and upwards of 10 episodes of wheezing approximately every 4 hours, with her latest episode of shortness of breath occurring this morning before coming to the clinic. She reports that her shortness of breath wakes her up at night twice, and she states that her symptoms are exacerbated by lying flat and also movement, which also induce a non-productive cough. She reports that her current symptoms are interfering with her daily activities, and she's concerned about the decreasing efficacy of her current albuterol inhaler. She reports that she's been hospitalized 5 times in her life for asthma since her diagnosis at age 2.5, with the last hospitalization being at age 16. She denies ever being intubated for her asthma diagnosis. She also denies recent use of spirometry or peak flow. She did not record or track her asthma attacks, and she denies use of home nebulizer or vaporizer. She states that she does not follow with a pulmonologist or allergist for her condition, and she denies the use of tobacco or any of those smoked products, and she states the last time she smoked marijuana was age 21. She denies regular exercise, and she denies knowledge of any environmental exposures in her home or workplace. Upon my physical exam, she appears in no acute distress. She is alert and oriented. She's sitting up in the exam table, and she has an appropriate affect and demeanor. The in-office spirometry yields an FVC of 3.91 liters, an FEV1 FVC ratio of 80.56, and a pulse ox of 97%. Upon inspection, her chest expansion is symmetrical with respirations. I noted normal fremitus, symmetrical bilaterally. Her chest is resonant to percussion without dullness. I did note expiratory wheezes auscultated in her bilateral posterior lower lobes, and muffled words also auscultated with notable expiratory wheezes in bilateral posterior lobes. I did not auscultate crackles. According to Gina, this case would be classified as an exacerbation of asthma, which is deemed as an acute or subacute worsening of symptoms and lung function, compared with the patient's previous status, with an exacerbation being regarded as moderate if it is troublesome for the patient. According to Gina, the use of SABAs alone can actually increase the risk of asthma exacerbation, lower lung function, and asthma-related deaths. My recommendation would be to switch the patient from her current SABA to an inhaled corticosteroid reliever, which she could then use as both maintenance and a reliever. Additionally, I would give her a given her current symptoms, I would give her a short course of oral corticosteroids to help minimize the symptoms at this time. The patient should be instructed if after 1 week she lacks adequate symptom control, we could potentially recommend increasing the inhaled corticosteroid to a medium dosing. I would educate the patient on the use of medications and compliance with the regimen, as well as advising her to reach back out to the clinic with any persistent or uncontrolled symptoms. And she should be scheduled for a follow-up in the clinic in 1 to 2 weeks to assess for improvement of symptoms and dose adjustments as necessary.